Dear students, today we will discuss the new topic, examination and investigations of respiratory system in normal adults. First of all, let's remind you organs of the respiratory system. Respiratory system consists of nose, pharynx, larynx, trachea, bronchi, and lungs, alveoli. Again, remind you the sequence of examination of respiratory system. First inspection, then palpation, percussion, and at last auscultation. Examination of respiratory system, we begin from the nose. It's necessary to ask the patient about difficulty of nose breathing, features of sense of smell. Inspect and palpate the nose. Note the shape, symmetry, tenderness. For an estimation of nose breathing, the patient is asked to displace right LNZ to nasal septum with his fingers and to breathe by way of left nases. Reverse the procedure to examine the other side. Then the patient's neck should be extended. Press on the tip of the nose to expand nostrils. This way allows examining a vestibule of the nose. After that, palpate the sinuses. Palpate the frontal sinus tenderness by pressing up from deep the bony brow on each side. Avoid pressure on the eyes. Then press up on each maxillary sinus. Then examine the larynx. Estimate loudness, timbre of the voice. Palpate the larynx. After that, we examine the thorax and lungs. General approach. The patient should be undressed to the waist. If it's possible, the patient is examined in sitting or standing position. There is a correct sequence of examination: inspection, palpation, percussion, and auscultation. Each method is applied to the anterior chest wall, then to lateral chest walls, after that to the posterior chest walls. While the physician is examining the patient's posterior chest wall, patient's arms should be folded across his chest so that his scapula are partly out of the way. Compare one side with other. Variations between patients are great. To some extent, at least, comparison of one side with the other allows a patient to serve as his own control. Work from above down. Chest examination includes landmarks on the chest wall, chest shape, and wall, and breast. Landmarks of clinical importance. These are bones on the anterior side are clavicle, acromion, ribs, and sternum. At posterior side, thoracic vertebrae, scapula, and acromion process. Then organs: lungs, bronchi, trachea, larynx. Topographic landmarks of the anterior, posterior, and lateral sides. At anterior side, thorax, first mid-sternal line, then parasternal line, mid-clavicular line, at lateral view, there are three lines: anterior axillary line, mid-axillary line, and posterior axillary line. And topographic landmarks of the posterior thorax are mid-spinal line, paraspinal line, and scapular lines. There are four fossas at the anterior side of thorax: suprasternal fossa, supraclavicular fossa, infraclavicular fossa, and axillary fossa. And also there are four regions. These are scapular region, suprascapular region, suprascapular region, interscapular region, and infrascapular region. We inspect the thorax for lesions, chest excursion, pattern of breathing, and obvious lesion. Normal chest shape is the ratio is anterior posterior size to transversal is 1 to 1.5. This pertains to normosthenic chest, and normal chest shapes are normosthenic, hypersthenic, and asthenic. Abnormal chest shapes are flat chest and barrel chest, rachitic chest, including pigeon chest, rachitic rosary, and funnel chest. Inspection of the thorax. In healthy patients, there shouldn't be any deformities. Chest anterior-posterior diameter in proportion to its lateral diameter, normally 1 to 2. Both half of the chest are symmetric. Static inspection. The shape of the chest. To estimate form of the chest, pay attention to pronunciation of supraclavicular fossas, pronunciation of infraclavicular fossas, pronunciation of intercostal fossas, direction and width of intercostal spaces and ribs, epigastrical angle, anterior, posterior, and lateral sizes, position of scapulas. The type of constitution determines the features of normal chest shape. Characteristic of normosthenic chest. Conic shape of the chest. Anteroposterior diameter is less than the lateral diameter. Visible sternal angle. The slope of ribs is moderate. The costal angle is 90 degree. Visible sternal angle is here. The height of the chest and height of abdomen are equivalent. Hypersthenic chest, characterized by cylindrical shape of chest. Anteroposterior diameter comes nearer to lateral diameter. Sternal angle is expressed considerably. The slope of ribs comes nearer to horizontal direction. Costal angle is more than 90 degree. The height of the chest is less than the abdomen's height. And at last, asthenic chest. The chest shape is flat. Sternal angle is not expressed. The slope of the ribs comes nearer to vertical direction. Costal angle is less than 90 degrees. The height of the chest is more than abdomen's height. And these are abnormal chest shapes: barrel chest and kyphosis. If you compare the normal chest shape, anterior-posterior size to lateral ratio is 1 to 1.5. Abnormal chest shapes: emphysematous or barrel chest resembles hyperstenic in its shape. Supra and infraclavicular fossa are absent or even protruded. The ribs are horizontal. The interspaces are enlarged. Epigastric angle is more than 90 degrees. The chest wall is prominent. Chest has an increased anteroposterior diameter, and that is why chest has a barrel-like configuration. Emphysematous chest observes in emphysema of the lungs. The lungs seem to be as if at the inspiration phase due to decreased elasticity of the lungs. The volume of the lungs increases. The natural expiration becomes difficult. It means expiratory dyspnoea. Accessory respiratory muscles active participate in the breathing act, especially sternocleidomastoideus muscle and musculus trapezius. Elevation and lowering of the entire chest during breathing become evident. A barrel shape is normal during infancy and often accompanies normal aging. Next, abnormal chest shapes are rachitic or pigeon chest, in Latin pectus carinatum, is a result of abnormal skeleton formation in childhood in the patient with rachitis. In a pigeon chest, the sternum is displaced anteriorly, increasing anteroposterior diameter, resembling the keel of the boat. The ribs meet an acute angle at the sternum. The costal cartilages thicken like beads at points of their transition to bones. And funnel chest, pectus excavatum, is characterized by a depression in the lower portion of the sternum near the xiphoid process. The deformity can be the result of abnormal development of the sternum or prolonged compressing effect, but exact cause is now unknown. Physical exam. First, the position of the patient for posterior and lateral is sitting position. Patient may sit or take supine for anterior position. Undressed from waist up. And never listen through clothing. General assessment. Inspect facial expression, posture configuration of chest. Anteroposterior diameter should be 1/3 to 1.5 transverse diameter. Define type of respiration, then respiratory rate and pattern. Participation of the chest wall in breathing act. Inspect hands for clubbing. Respiratory movements. In the lying supine position, respiratory movements of the chest are less expressed than respiratory movements of the anterior abdomen wall. In sitting position, amplitude of movements of the chest is appreciably increased. Normally, both halves of chest move synchronously. There is not bulging or retraction of the interspaces and supraclavicular fossas during inspiration and expiration. At the rest, the accessorial muscles, musculus trapeziae, musculus sternomastoides, musculus calenus, and abdominal muscles do not participate in breathing. The breathing rate, depth, and regularity. A normal resting adult breathing quietly and regularly about 14 to 20 times per minute. In the lying supine position, rate of breathing on 2-3 breaths is less than in standing position. In order to determine respiratory rate, count the movement of the chest or abdominal wall, with patient being unaware of the procedure. Ratio of respirations to heartbeats is 1:4. Note the rhythm, regular, irregular, and the way the chest moves, not too shallow or too deep. And these are the types of abnormal rhythm. Orthopnoea, shortness of breath when lying down. Platypnea, dyspnea increases in the upright position. Tachypnea, the rate is more than 20 per minute. Bradypnea, the rate is less than 12 per minute. Hypopnea, abnormal shallow with pleuritis. Hyperpnea, rapid deeply with increased VOB. Kussmaul's breathing, deep and rapid metabolic acidosis. Cheyne-Stokes, regular with periods of apnea followed by crescendo-decrescendo sequence. Biotes, somewhat irregular, varies in depth. Cyanosis, see lips and inspect nasal flaring. Palpation of the thorax. To assess further the shape of chest, determination of expression of sternal angle, slope of the ribs, width of costal angle. To detection of any tenderness. To check of trachea's position. To access further the respiratory excursion, and to elicit vocal or tactile fremetus. At posterior chest, palpate for any tenderness or abnormalities, for example, nodules. Measure posterior chest excursion. The posterior chest excursion should be symmetrical. Thoracic expansion during respiration. Watch and feel for symmetry. Watch the movement of your thumbs. How to elicit vocal or tactile fremetus. Fremetus refers to the palpable vibrations transmitted through the bronchopulmonary system to the chest wall when the patient speaks. Ask the patient to repeat the words 99. If fremetus is faint, ask him to speak more loudly or lower his voice. Also, normal lung transmits a palpable vibratory sensation to the chest wall. This is referred to as fremitus and can be detected by placing the ulnar aspects of both hands firmly against either side of the chest while the patient says the words 99. This maneuver is repeated until the entire posterior thorax is covered. The bony aspects of the hands are used as they are particularly sensitive for detecting these vibrations. Palpate and compare symmetrical areas of the lungs, anteriorly, laterally, and posteriorly, using the ball of your hand or more sensitive ulnar border of your hand. Identify and locate any areas of increased, decreased, or absent fremitus. Vocal fremitus is typically more prominent in men than in women and children, in the upper lung fields than in the lower one, and more prominent on the right side. Voice transmission is better through the shorter right main bronchus than on the left. Vocal fremitus is increased in consolidation of the pulmonary tissue and also in the presence of an air cavity communicated with bronchus. Vocal fremitus is decreased when the voice is soft in emaciated patients or when the conduction of vibration from the larynx to the surface of the chest is impeded. Causes include separation of the lung by moderate amount of fluid or air, by fibrosis, obstructive atelectasis, and also a very thick chest wall. Vocal fremitus can be absent when significant amount of fluid or air are accumulated in the pleural cavity. Next method of examination is percussion. Percussion is determine whether the lung tissue is air-filled, fluid-filled, or solid. There are two types of percussion, comparative and topographic. Pay attention, the comparative type of percussion is always first. Normal percussion sound is resonant, and these are the abnormal percuting sound, dull, tympanic, flat, and hyperresonant. Comparative percussion. For comparative percussion, use the light percussion. Percuss the anterior chest wall, comparing symmetrical points from supraclavicular areas to a third intercostal space along mid-clavicular lines. If it's necessary to use only interspaces. Above normal lungs, there is an area of resistance. The heart normally produces an area of dullness to the left of the sternum from the fourth to fifth interspaces, heart dullness. After that, continue percussion downwards on the right side. As you percuss below the fifth interspace on the right side, the sound will change to a higher-pitched dull note. It's the liver dullness. After that, percuss the lateral chest walls in mid-axillary lines on the right side from resistance to liver dullness and from resistance to splenic dullness. While the patient continues to keep his arms folded across his chest, percuss symmetrical areas of the lungs from resistance to diaphragmatic dullness. here the comparative percussion at posterior thorax. This is the sequence of comparative percussion, the same side, the same place, and go down. Topographic percussion. The aim of topographic percussion is determination of the top of lung apices and determination of the lower border of the lungs. We percute on in front of patient at the from 3 to 4 centimeter higher than clavicle, and behind of the patient at the level of the 7th cervical spinous process. Determination of Kröning's areas. Percuss across the top of each shoulder to identify the approximately 5 centimeter band of resonance overlying each lung apex. Determination of lower border of each lung. With your placimeter finger parallel to the expected lower border of each lung, percuss in progressive steps downwards in all vertical line during quiet respiration. For topographic percussion, use the light percussion. Place your placimeter finger both on the intercostal spaces and on the ribs. These are 7 vertical lines at which we should determine the lower border of lung. On the right lung, we should determine at 7 vertical lines, beginning from parasternal lines and ending by paravertebral lines. On the left lung, we don't use parasternal line and mid-clavicular line due to heart dullness. When we examine the posterior chest, we should measure also diaphragmatic excursion. Normally, it should be 3-5 centimeters. The diaphragm is normally higher on the right. Diaphragmatic descent may be limited by pulmonary lesions, abdominal lesions, or pain. Measuring diaphragmatic excursion. Ask the patient to inhale deep and hold their breath. Percuss along the scapular line until you locate the lower border. Mark the point where resonance turns into dullness. Ask the patient to take several deep breaths, then exhale as much as possible. Percuss down from the marked point and again mark where resonance turns into dullness. Measure the distance between the marks. Diaphragmatic excursion may be measured by noting the distance between the levels of dullness on full expiration and full inspiration. And in this table you can see the normal diaphragmatic excursions at mid-clavicular line, mid-axillary line, and scapulary line. On left lung, we don't use mid-clavicular line. And the last method of examination is auscultation. Breath sounds occur as a result of the movement of air through the trachea, bronchi, and alveoli. Use diaphragm of a stethoscope. Have client breathe through mouth more deeply than usual. Visualize the right lung is divided into 3 lobes, the left in 2 lobes. Apex is at the top base at the bottom. Sounds are assessed side to side, anterior and posterior. The middle lobe is best assessed on the right side under the arm. Auscultation of lungs with the diaphragm of a stethoscope. Listen to the patient's lung as he breathes through his mouth somewhat more deeply than normal. Again, like in comparative percussion, you listen the same symmetrical places of both sides. This is at posterior thorax, here in lateral thorax, then anterior. Breath sounds above the lungs. Normal sounds are bronchovesicular and vesicular. Vesicular sound characterized by soft, low heard in periphery and base of lungs. Bronchovesicular has medium pitch, heard between scapula and anteriorly close to sternum. These places. Vesicular breath sounds. What you hear over most of the lung are soft, relatively low-pitched sounds that last through inspiration and fade out of your range of hearing relatively early in expiration. The ratio is 3:1. Although the expiratory component of vesicular breath sounds seems short to the human ear, expiration in fact continues, lasting longer than normal inspiration. Vesicular breath sound may be decreased when the patient fails to breathe deeply enough or has a very thick chest wall, as in obesity. Bronchovesicular breath sounds is medium pitched, heard between the scapula and anteriorly close to sternum. We can hear both inspiration and expiration phase of respiration. Tracheal breath sounds. You can hear these sounds over the trachea. Very loud and high-pitched breath sound. Duration of the inspiration is equivalent to the duration of the expiration, but there is a gap between the inspiration phase and expiration. Bronchial breath sounds. Note that the trachea bifurcates at about the level of the sternal angle anteriorly and the fourth thoracic spinous process posteriorly. In norm, bronchial breath sounds can be listened over the manubrium or between the scapula, especially on the right. These are loud and high-pitched sounds. The expiratory sounds last longer than inspiratory ones. The exhalation is more rough and louder than the inspiration. Abnormal breath sounds. Adventitious abnormal breath sounds occur when air passes through narrowed airways filled with fluid or mucus superimposed over normal breath sounds. Crackles, fine rails, high-pitched crackling sound. These are fine crackles, medium crackles, and coarse crackles. Rhonchia primarily heard over the trachea and bronchi. This can be due to fluid or mucus in the larger airways and characterized low-pitched, coarse sounds, heard during inspiration and expiration, may be cleared with coughing. Wheezes can be heard over all lung fields, airflow through narrowed bronchus, high-pitched musical sounds heard during inspiration and expiration. Pleural friction rub heard over anterior lateral lung field due to inflammation in pleura. Dry, grating quality, does not clear with coughing. And the last is the instrumental methods of inspection of the respiratory system. These are ventilation perfusion scan, ventilation, diffusion, perfusion, arterial blood gas analysis. The first method is spirometry. Spirometry is a method of assessing lung function by measuring the volume of air that the patient is able to expel from the lungs after maximal inspiration. It's a reliable method of differentiating between obstructive airways disorders and restrictive diseases. Aside from being used to classify lung conditions into obstructive or restrictive patterns, it can also help to monitor disease severity. This guide aims to provide a basic approach to spirometry interpretation. Spirometry provides several important measures including forced expiratory volume in 1 second, the volume exhaled in the first second after deep inspiration and forced expiration similar to PEFR. Next, measure for forced vital capacity, the total volume of air that the patient can forcibly exhale in one breath. FeAV1 to FeVC is the ratio of FeV1 to FeVC expressed as a percentage. Values of FeV1 and FeVC are expressed as a percentage of the predicted normal for a person of the same sex, age, and height. Next instrumental method is peak expiratory flow rate. It describes maximal airflow rate in a given time. We determine by peak flow meter. And arterial blood gas analysis determined by pulse oximetry. Next method of inspection is imaging studies like chest X-ray and echo KG. In normal patients, average pulmonary arterial pressure is less than 24 millimeters. Thank you for attention.